Hey y'all, this is Richard Santucci and welcome to my AMA. So I'm a genital conformation surgeon at Crane Surgical Services, and we're going to talk today about metoidioplasty. Big word with a interesting history. So a lot of you have submitted questions ahead of time, and we're going to work through those questions. If you have additional questions, just go ahead and put them at the bottom of the Facebook page in comments, and we'll try and get to them and answer them. So Facebook's got a limit of an hour for these things, so if we can get to your questions, we certainly will. Okay, question 1. What is a metoidioplasty and why does it have such a weird name? Yeah, it is a pretty big weird name, and it's based on a Greek word because for some strange reasons doctors use Latin and Greek a lot. I think in the Middle Ages it made us appear very intelligent, and so they did that, and we're stuck with that. So there's a word in Greek called metoidios, which means moving towards, and really the inventor and conceiver of this operation felt that it was a surgery that was moving towards the masculine state for trans men. In a full metoidioplasty, lots of things happen that can help a trans man reach his goals. The first is the vagina can be removed. After removal, you get a nice flat male-type perineum. Secondly, a scrotum can be formed. Thirdly, the urethra can be lengthened so the pee will come out the end of the phallus, and some people can stand to urinate, which is a goal. And finally, the clitoris is freed up so that it can be lengthened to its maximum possible length and creates a sort of male-type phallus. And so for a lot of people, this meets their goals. And it ends up being a really good operation for some. Now realize that every one of those elements is not mandatory. So if you wanted to leave the vagina in, you can. Don't want a scrotum? Okay. Don't want to lengthen the urethra? Great. There even is a kind of procedure called a simple metoidioplasty, which is really just the lengthening part that I described, and maybe with a scrotum placed, but then the vagina is left in place, the urethra is not lengthened, and that ends up being, for people who wish that, kind of a low-key operation with not so many complications that does really well. I'm sorry to go on and on, but I do want to talk a little bit about staging. So most of the operation is done in the first step. But there's a really important second stage at about the 6-month mark. And at that time, I do what I'm calling a buried penis operation, because we borrow a lot of the procedures that were used in cis males with a severe problem called buried penis, and we make the phallus more prominent. So the first thing that's done is what some people would call a monsplasty, but which I call an escutcheonectomy, because that part of your body is the escutcheon or the shield. And in that case, an oval of tissue is removed, and the whole penis and scrotum complex is moved up a little bit to good effect. It also makes a nice flat landing area for the phallus, making it more prominent. Also, after we do this procedure, we have to be really nice to the flaps that make your scrotum, and the blood supply all comes in from the top, so we can't mess with the top of the scrotum at all. But that always leaves a kind of poochy bit right next to the phallus that needs to be reduced. So I call that an upper scrotal reduction, and that's part of it. Some people also will get a little bit of kind of scar connection down to the scrotum, which needs to be freed up. And all of those things usually make for a much more prominent phallus in the second stage. In that second stage as well, if appropriate, then we'll put in testicular prostheses. Big answer for a short question. Okay, next one. Will I lose clitoral sensation with meta? Well, you know, one of the good things about the meta is that we don't really mess with the nerves to the clitoris at all. The clitoris is this downward facing, very adherent structure, and we free up all of its adhesions completely, making it kind of upward facing, outy structure. But we don't mess with the nerves, arteries, and veins that run along the top part. And usually patients tell us that the sensation to the phallus is completely preserved, which is a cool benefit of the operation. Okay, what is the proper way to measure how much growth you have? So I think what that refers to is that when you take testosterone, then you get some enlargement of the clitoris. And the larger the clitoris, then naturally the larger the phallus is after metoidioplasty. People are very concerned about clitoral length, but I am less concerned about clitoral length. Really, you're going to get what you get. And so we don't know exactly how long all of the masculinizing benefits of testosterone take, but it probably takes a solid year, maybe more like 2 years to get maximum clitoral growth. But at that point, your clitoris is the size of your clitoris, and we can generally make it work for metoidioplasty no matter what size you got. Okay. How long with a catheter post-op? So if you elect for a urethral lengthening, that's a fair amount of operating on your urethra, and that urethra is not ready for prime time yet. So we have to put in a suprapubic tube, which is a kind of urinary catheter that goes right into the skin of your lower belly. You may or may not know that your bladder goes all the way up to your belly button. So if we put a catheter right through the skin, boom, it goes right into the bladder. And you'll have to wear that for about 3 weeks after surgery. That's the worst part of the operation, by the way. If I can figure out a way to make that better, I'll retire happy one day. If you don't have a vaginectomy, do you still have to have a hysterectomy? No. So I will emphasize that these are custom surgeries. And really, it's almost checklisted, like vagina in or out, urethra long or short, scrotum yes or no. So you can really tell us exactly what you want. There are some implications of those decisions, good and bad. So if you wanted to leave your vagina in place and then not have a hysterectomy, that would be completely reasonable. On the other hand, let me say, if you're planning to have a vaginectomy, you must have a hysterectomy. That is removal of the uterus. And you need to have that at least 3 months before the surgery so you can completely recover. We'll talk a minute about doing them at the same time, but in general, you want to do it 3 months beforehand. The other thing that you need, please, is that your surgeon that takes out your uterus needs to do a speculum exam when you're fully healed, because it's rare, maybe 2% of the time, but sometimes the vaginal cuff doesn't heal. And if I go in to do a vaginectomy and the vaginal cuff is open, what I'm seeing is your intestines, and the operation has to be aborted. So we don't want to abort your operation. So to make sure that doesn't happen, in the rare case where you don't have good healing of that vaginal cuff, you need to have it well ahead of time and be checked before your metoidioplasty surgery is scheduled. What else? What are the most common complications with META? So the one piece of good news about META is that it's a reasonably smaller procedure than, say, phalloplasty. Phalloplasty has a lot of complications. META has some complications for sure, but it's always less than phalloplasty. So let's talk about them sort of going bottom to up. The first is that, when I remove the vagina, what I'm going to do is physically take out about 4/5 of the vagina. So the mucosal lining is removed completely, sent to the pathologist's office. You and I will never see it again. There is a little cap of vagina that also could theoretically be removed. The problem is if you remove it, then the intestines come out again. You remember that story from before? So what we do is we use electricity to completely destroy that cap so that it doesn't function anymore. And then sutures are used to bring the tissues together and ultimately end up with a nice flat male-type perineum. That wound can sometimes not cooperate and not heal fully or properly. And in that case, at the 6-month mark, when we do a second stage, we'll just add on a fix to any wound problem. The second issue is the scrotum. You know, these rather long flaps are taken and origamied up to make a scrotum. And that's a lot of suture lines. And so it is possible, you know, when we ask your body, when we sew something together, we're just sort of asking your body like, hey, can you do me a solid and knit this together? And sometimes it does and sometimes it doesn't. So if you get gapping there, a lot of times that can be very visually scary to you, but almost always it heals on its own. Rarely we'll go in and put a couple extra sutures in a procedure called a delayed primary closure. Not commonly, but rarely we'll do that. But anyway, problems with the scrotal flaps are pretty common. I think almost everybody should expect to have a still partially buried phallus after the first stage meta. It's really only after the second stage that meta comes out and does its thing. I think those are probably the big ones. Urethral fistula, so a fistula is an abnormal opening in the urethra, can happen. And that either happens at the bottom of the scrotum or right near the tip. And that's generally pretty reasonable to fix. Urethral strictures also happen. That's a narrowing, but you know, we're reconstructive urologists, and without tooting our own horn too much, I will just say that I think we just know our way around the urethra, and we just don't seem to have a lot of urethral strictures. I'll finish by talking about a really important concept. So, in the very specific case that we leave your vagina in, but you still want a urethral lengthening, that's very treacherous for causing stricture. The stricture rate might be 60% in that place. Excuse me, I said stricture, but I meant fistula. The fistula rate can be up to 60%. Why is that? Well, we're going to leave the vagina in place, which means I can no longer borrow some of the tissue around the vagina to glom onto the urethra and make a second good layer. So now I'm missing my second good layer that I usually use, and that's why the fistula rate is so sky high. So you have to give special thought if you're going to lengthen the urethra but leave the vagina in, because you and your surgeon have to accept an unusually high risk of having a fistula, which will have to be fixed later. Okay. Is there a required amount of bottom growth to be eligible for surgery? I'll refer back to what I said before. I mean, what you've got, if you've been on, you know, high-dose testosterone for 2 years, you probably got what you're going to get. And it's reasonable to proceed. So, will FTM still experience growth post-op from testosterone? Probably not. I mean, you know, I think some growth happens to everybody. Most people don't get a ton of growth. And I think growth stops after a while, maybe to maximum 3 years. Okay, if I don't get urethral lengthening, where will the urine come out? Great question. So in the case of urethral lengthening, the urethra is left exactly the same place as it is now, before surgery. And so we just don't mess with it. We leave it where it is, and so you'll have to sit to urinate for the rest of your life. Now, if standing to urinate isn't really important to you, that's actually a really spiffy way to decrease possible complications, because it seems like most of the complications of this surgery come from the urethra. And if we make the urethral part not happen, then you can't have complications there. So if you're one of those people that standing to pee is just not that important, then you can consider not having a urethral lengthening, and you'll get some benefit out of that. Can I quickly say, though, that if you don't do urethral lengthening and later have things like a scrotum made and a metoidioplasty portion of the phallus operated, you can't get a urethra built later. So that's a permanent decision that you're making not to have urethral lengthening. So consider carefully, please. Okay, how do I prepare for meta? Well, some of preparation for meta is the same as preparing for any surgery. So we, of course, follow WPATH guidelines, which requires 2 letters from a mental health professional and 1 letter from your hormone provider. So start from there. Secondly, we don't really need any hair removal for this, so you can rest easy on hair removal. Thirdly, scientifically, we still don't know what is the perfect amount of adiposity or body weight that you'd still be safe to have surgery. Right now, we have a pretty generous cutoff of a BMI, which is one way to measure adiposity, of 37. You have to realize that if you were in the heavier range, it could be difficult for you to stand to pee, because if you have a lot of body tissue, it could be blocking the phallus to the point where it's really not out enough to pee, or that you may need to kind of push your fingers on either side to kind of pop it out when you pee. I do feel like the second stage operation, remember the one that I called the buried penis operation? I believe that can truly improve that a lot, but if you're extremely heavy, you probably have a lower chance in being able to stand to pee if that's one of your goals. And I think the other preparation thing is just think it through and decide if you want a vaginectomy, yes or no, want a urethral lengthening, yes or no, and want a scrotum, yes or no. So pretty simple. How many weeks off work, out of the gym, and off of a bike? Great question. So, the vaginectomy portion of this procedure is kind of the biggest hit to you. You're pretty sore. It's hard to sit for a long time. You might need pain medications. And so I believe that a full meta, including a vaginectomy, may mean that you're going to be off work 3 or 4 weeks, especially depending on what kind of work you do. Remember that you're going to have a suprapubic tube for 3 weeks. And so while some people tough it out and go to work with the suprapubic tube, I wouldn't want to go to work with the suprapubic tube. So it may be reasonable to stay home. If you do really heavy work, I've had police officers or firefighters who are extremely physical, then you may need to plan to take more weeks off work. Because we're not doing a lot of deep surgery, say on the abdominal wall, heavy lifting should probably be avoided for about 6 weeks, but then you can get back to pumping iron and things like that at the 6 weeks mark, and ditto on bike. A general guide on doing things physically after any surgery: check with your surgeon to see what's allowed, because sometimes abdominal surgery, it's no heavy lifting greater than 10 pounds for 6 weeks because you'll blow out the sutures. But when you do get back to things, go slow and listen to your body. If it hurts, stop. Even going back to work, I've always told people, if you can manage, if you have a kind of work situation where you can go back half day for a couple days, just do that, just to make sure you're really ready, fit for a full 8, 10, 12 hours at work like some of you do. Okay, next one. Can I get phalloplasty after I've had metoidioplasty? You absolutely can. So up to 20% of the people who've had metoidioplasty later decide to get a phalloplasty. And that, to me, is a good thing, not a bad thing. For starters, it's possible. Secondly, in some ways, it makes the phalloplasty much easier, because think about it. You've already had so much of the operation. You've already had your vaginectomy. You've already had your scrotum. You've already had your urethra lengthened. And so all of those things don't need to happen again. So you can't have complications from that part of your body anymore. So to me, staging this by deciding, in your 20s that you think a meta is right for you, and then perhaps deciding in your 30s that you'd like to move on to have a phalloplasty, is a super reasonable way to do this sort of masculinizing surgery. So anyway, I like that because it means the meta is not the final destination for you if it doesn't necessarily work perfectly for you. How long do I need to stay in the area? That's a little bit negotiable, but it looks something like this. So in general, we're going to do this operation. If we don't do a vaginectomy, we're going to let you go home that day. And then I'd want you to come back to clinic the following week without fail, just to make sure you're okay, no problems, things like that. At that point, if you're really doing well, let's say you live a couple hours away, we can discuss you going home and either doing a telephone visit if you're really doing perfect, or just coming back for the actual visit. If you're far, far away, you probably need to spend a solid 3 weeks here in Austin with us. It can be very challenging to find a local surgeon with the knowledge and willingness to jump in and care for you if you have a problem in that first 3 weeks. So if you're living far away, it's 3 weeks. If you're living closer, talk to us about it and we'll see what we can do. Okay. Will I be able to have penetrative intercourse with my new phallus? Well, the major benefit of this surgery is it doesn't mess with the nerves associated with your new phallus. So whatever sexual function you have is still going to be preserved, so that's good. Whether you're able to have actual penetrative intercourse really depends on the length of the phallus. But I don't know any way to say this other than to say my patients seem to figure out how to have sex with this pretty well, and it seems to work with them. And whether that's penetrative intercourse or something close to that, I don't know, but it works still. Okay, will I definitely be able to stand to pee with my penis? I'll tell you, in medicine, the word definitely is probably always a never. So, no, not definitely. So, if you are a rather slender person with pretty good length after testosterone, probably I'm going to say that you're going to be able to stand to pee. If you are a heavier person or a person with less clitoral growth, I'm actually also going to say probably you're going to be able to stand to pee, but I think you have less chance. It won't be 100% or 90%. It might be 60 or 80% of people. Let's agree, too, that they're standing to pee and standing to pee. One of our meta patients made some very helpful videos of him peeing. Sounds gross, but it was really important that people could see the postoperative result. And because he's an experienced meta patient, he took 4 videos. 1, peeing with no pants on. 2, peeing with pulling the pants down. 3, peeing with kind of pulling the pants over. And 4, peeing through the zipper. Peeing through the zipper, like as at a urinal in a public bathroom, is kind of the holy grail. And it's just not going to be possible for everybody. Maybe 50% of all comers. I truly don't know the real number, but I don't want to oversell this operation to anybody. But certainly figuring out a way to stand to pee with the right clothing on, or by maneuvering your clothing, is going to work for a majority of patients. Okay, can I get testicles, and can I get them the same time as meta? So part of that second stage operation is placement of testicular prostheses. So yes, you can get them, and we do that at the 6-month mark after surgery. You really don't want them at the same time as meta, because imagine this really complicated origami scrotum. And let's say you get a wound problem somewhere along this very complicated suture line. If the wound separates, then we're going to be looking at your testicular prosthesis. It'll be naturally colonized or even infected with bacteria, and the prosthesis will have to come out. So I'll emphasize that we do a kind of modern form of scrotoplasty, where the scrotum in the old days, 20 years ago, used to be kind of stuck down in the perineum and not very scrotally looking and kind of bifid. And in those cases, sometimes people put in a prosthesis at the same time. We do kind of a modern procedure where the scrotum is taken up and out from between the legs. It makes a kind of round, scrotum-y looking scrotum, much nicer looking than before. And in that case, it's only reasonable to do prosthesis after at least 6 months of healing from surgery. Okay. Can my new phallus look circumcised? So this relationship of skin to the phallus and meta is actually pretty complicated. So I'm going to say a lot about skin on the phallus right now. The first is that when we lift up the phallus, realize it really doesn't have any coverage on the under part. It used to be like that, no coverage. So when we go like this, we have to borrow this skin to kind of bring around and cover. So that ends up kind of tightening up and the skin and kind of making it look like skin naturally drapes on a cis-male phallus. Having said that, at the second stage, we've seen all kinds of interesting issues with the skin. One might be that there's really just a lot of skin draped there and it just doesn't quite look right. In that case, we can revise that skin. The other problem we've had a couple times is that imagine that the skin is really loose and kind of slips over the top of the phallus. It can make kind of a scar ring here, and the phallus can't come out. If that was a cis male, you'd say he had phimosis and needed a circumcision. So in that case, we have to cut that scar ring and reconfigure that so that doesn't happen again. So I guess what I'm saying is that the configuration of the skin in a meta is kind of like a circumcised male, cis male from the get-go. And some people need small revisions of the skin to make it just right if the phallus slips behind a sleeve of skin or there's just too much skin draped there for your comfort. Will my new phallus be self-lubricating? No. So cis-male phalluses are not self-lubricating, and your phallus won't be self-lubricating. Now there is some tissue on the underside of the clitoris that is got mucus in it, but we're going to borrow all of that to make the urethra with. So we're going to take that tissue and tubularize it to make your urethra. So any of that former paravaginal tissue or tissue underneath the former clitoris is going to be borrowed to make the urethra. So if you're thinking about that tissue, it's not really on the outside of your phallus to provide any self-lubrication. You're going to have to use lubrication like the rest of us. Can I get an erection? Yeah, I mean, I would say that most trans men with unoperated genitalia who are on testosterone are probably getting tumescence and rigidity of the clitoris in its native position. And when we free up the clitoris and make it an outie, that same kind of hardness with sexual contact should happen. So I'm thinking you're going to get what you got before, and I think most people get really good tumescence of the clitoris. Okay, if I get urethral lengthening, where does the urine come out? So we endeavor to make that urethra go all the way to the tip, and we don't always get there. So the urethral opening will be right at the tip of the phallus. This helps to make a nice directable urine stream. It might help with standing to pee. But, you know, this little bit of tissue here, we're really asking a lot of it. We're kind of taking it far from its home. We're operating on it, sewing on it. And sometimes that opening will retract back a little bit. If that's really severe and you have a urethral opening that's just down on the shaft, we can fix that for you in the second stage. But the goal is pretty much tip of the phallus. Let's see. How soon after surgery can I have sex? There's sort of sex and there's sex. So what I tell my patients may be similar to what I tell them about exercise. So don't mess around down there like at all until you're fully healed. That's going to take 3-4 weeks. I don't really want any vigorous sexual activity until at least 6 weeks. You really need to be fully healed. And I do have a fair number of patients that say, hey, I tried this at week 2 and now everything's red and swollen. And I'm thinking, yes, that definitely happened. So if you can go easy and leave that area alone until you really don't see any open areas or any areas that need to heal further, then you can start to mess around a little bit and don't really go for anything vigorous until the 6-week mark, please. Aside from testosterone, are there ways to increase the size of my clitoris before surgery? I don't know the answer to this, and I'll tell you what I don't know. There are some vacuum devices that can be used in metoidioplasty. Now, I'll tell you how I use the vacuum device. So after the metoidioplasty, say a week or so after surgery, when you're starting to heal up a bit, if you could purchase and use a vacuum device, and they have vacuum devices that are contoured to the meta-size phallus, a couple times a day, I think that may help to pull the phallus out. It won't make it longer magically, but instead of maybe scarring in, maybe it scars in the out position. So I do go for that. I don't have scientific evidence that helps. Some people have advocated pumping beforehand, and I just can't tell you scientifically if that helps or not. My hard feeling is that it doesn't help much. If you wanted to do it, to give yourself every option because you just want to do it, please go ahead and do it. But I have a hard time telling all my patients to please do it before surgery because I can't seem to find scientific evidence that it really does anything. Do I have to be on testosterone to be considered for meta? So this is an interesting question. So if you look at the WPATH guidelines, it says that we need 2 letters from mental health professionals and 1 from your endocrine provider. And the theory is that the endocrine provider is going to document that you've been on hormones for a year. Having said that, patients who are never going to be on hormones, that is not their plan, do not need to willy-nilly start hormones for this operation. So if you are a non-binary person, transgender person who simply, or trans man that simply doesn't want to be on testosterone, someone who can't safely be on testosterone, there's absolutely no need for you to be on testosterone. We simply document that testosterone is not your gig and you will not be on it, and that's fine. But there's no need to sort of artificially put yourself on testosterone because part of the WPATH guidelines are to document that you've been on hormonal treatment for a year or more. Are there visible scars from meta? So yes, there are. In the second stage, how much a scutchenectomy, monsplasty, penile lift, they're all sort of the same operation, same incision, has a lot to do with your body conformation. So sometimes the incision's like this, sometimes the incision's like that. So that means you may have a low incision on your belly. You may have some easy to hide incision in your upper scrotum, but then there's hair on the scrotum that seems to work for that to cover, and the scrotum seems to heal pretty well. And your origami scrotum has a lot of suture lines, of course. But I'll tell you, over time, most of those suture lines really fade and they just look pretty good, So I don't see it as a really Frankenstein-y kind of operation. Okay, I'm going to pull some of your questions live from the Facebook feed. Do I need to stop testosterone before surgery? No, you don't. So, it's very disruptive to stop hormones. And we don't think there's a health benefit to stopping your hormones willy-nilly. So go ahead and just take your testosterone as always. The only thing I might say about that is if you're someone who takes a depot-type testosterone maybe every 2 weeks, it might be best to time it so that you take your testosterone and somewhere near the end of that 2 weeks we give you your surgery and then you take your testosterone again after surgery. Is that necessary? Probably not, but it might be one way to just kind of finesse it so you don't get a massive dose of testosterone and then have surgery the next day. Does it matter scientifically? I'm not sure. I don't think any of us know. How often do meta patients later change their mind and get a fallow? Does this make the fallow harder to accomplish? This is an important subject, and so I'll go over it again because I think it's important. Up to 20% of patients that have metoidioplasty later decide to have a phalloplasty. But if anything, it makes the fallow much easier because just think, on that day, we do our phalloplasties as a one-stage operation. We think there's great evidence for that. We've done more than 750 cases exactly that way. And while some fine centers decide to do multiple stages, we simply have not felt that that's an improvement on this operation, and we don't think it helps the patient at all. So we do everything in the same day. So the day you have your phalloplasty, you get a vaginectomy, urethral lengthening, scrotoplasty, and phalloplasty. So imagine that you're a meta patient moving over to phalloplasty. Well, now you need much less surgery. No vaginectomy, already been done. No urethral lengthening, already been done. No scrotoplasty, already been done. And so we think that our phalloplasty after meta patients do especially well. So I love that meta isn't the final word if it doesn't meet all your goals. I love that, if you're at a point in your life where meta makes sense for you, but it doesn't later, it's not a decision that has been set in stone. So it's one of the benefits of the surgery, in my opinion. Let's see. How do I choose between meta and fallow? That's a tough question for the surgeon to answer because I feel that my patients are extremely knowledgeable. You have done your research, you've been online, you've talked to your friends, heck, you've seen post-op pictures of good and complicated patients. You really know a lot. And, if meta makes sense for you in your head, then it makes sense for me. If only fallow is going to do the trick for you, then also we'll help you with that. So it's very difficult for me to say, this is why you should have meta, this is why you should have fallow. It's really my patients who tell me, I've thought a lot about this, I've researched a lot, and this is where I am. And my job is to help you get there. So I think we're almost done. Can you guys grab the testis prostheses? Let's have a little testis prosthesis lesson while we're waiting for more questions. I'm just looking at my question list because some of these are repeats and I don't want to repeat them for you. This one says, does a Mons resection improve the location of my phallus? Yeah, yes. The answer is yes. And the answer is a little bit prickly because we really don't do what you would call a Mons resection. We do something better and more thorough, which I would call an escutcheonectomy / penile lift. So this does a lot. It does flatten the Mons, good. It takes other belly fat from that fupa area, so not your belly, but the area above your genitals. Makes a nice flat landing zone. And it tends to lift the whole phallus and penis sort of up a little bit to good effect. So people seem to really appreciate that operation when it's done as part of the second stage. Okay, so these are testis prostheses. There's two major types. One is a kind of silicone prosthesis that is filled with saline. This one happens to be filled with air. And we fill this to a point where it's nice and soft, just the same as a cis male testis. These are made by Coloplast. They come in several sizes, as they all do, and they work very well. I think you'd have a hard time telling if we put one or the other in. I don't know that it really makes a huge difference which one of these you have for your lifestyle. This one is by AART, and I call it a gummy bear prosthesis because it's sort of solid silicone like a gummy bear. these have some benefit in that it can be shaved down if I need to contour it and change the size to better fit your scrotum. A little bit, let's talk about testicular implants. So two important things to know. One is that we shouldn't put in too big a testicular implant. If I sort of ram in and cram in too big an implant, two bad things can happen. One is it can just pop right out of there into your groin, and you won't thank me for that. And the second is that if we stretch that somewhat fragile skin that makes up your scrotum too much and it doesn't get a good blood supply, and if that skin dies, then it can expose the prosthesis and we have to remove it. So that's a bad deal. So it's much better to put the right size testicular prosthesis in there. If people are really motivated to have a larger scrotum over time, I think the safest way to do that is to place reasonable size testicular prosthesis. This is small, this is medium. And wait a year. Over the year, these are sort of acting as tissue expanders. They're sort of pulling down on the scrotum, and you will notice a larger, thinner, fuller scrotum. And then at that 1 year mark, you can then upsize to the next size. And that's a very safe and reasonable way to get a larger scrotum. Some people elect for tissue expanders, but honestly, I'm going to tell you that tissue expanders are a rough road in scrotoplasty. They are a very tough thing to deal with. They often erode or infect and have to be removed. When you get a tissue expander placed, we place that in your scrotum, and then you have a kind of button underneath your skin, and you have to poke that with a needle and inject it and put more saline in as the months go on. And it's kind of a hard road to hoe. So, all right. Here's another question. If I am listed as a male on my insurance, how do I get coverage for Histo plus Meta? So, insurance is a challenging issue, and I'm surely not the insurance expert here that's going to solve this problem, but I do know a thing or two about this. One of the important things that I know are that we have a team of insurance ninjas that basically work for you. So what happens is that you get us your letters, you say, I would like to have this kind of meta, we get you a date, say August 1. The date needs to be several months, at least 3 months in the future, so we can wrangle with the insurance company. Then we approach your insurance company and say, okay, here's the procedure, this is what we'd like to do. So little things like listed male, because you haven't been able to change that yet, because a lot of states you can't change it until you have gender confirmation surgery. I mean, we get that. A lot of our patients have a gender non-congruence on their paperwork, and that's fine. So that itself should not give you a problem. And the same thing for hysterectomy. Our patients seem to be able to get hysterectomy covered reasonably by insurance, no matter where they are in the continuum of changing their paperwork. So I say, I've never seen that exact scenario, but or heard the results of that exact scenario, but I believe that you're going to be okay with that situation. Okay, what is the most appropriate way to get histo before or during meta? So I think the best way to do it is to get the hysterectomy, recover, get all better, have a speculum exam to make sure you're not in the 2% of people that hasn't been able to heal their vaginal cuff, and then 3 months or more later have a metoidioplasty. If you make us, we have some consultant surgeons that will come in and do your hysterectomy the same day as the metoidioplasty. But I'm telling you, it may be convenient, but it's a lot of surgery for one day. And the recovery from the meta is big enough, and recovery from hyst can be big enough, that ramming those two recoveries together, I just don't know if it's worth it. I know it's convenient to get it all done at the same time. And as I say, if you make us, we'll probably agree with you and do it, but it wouldn't be my first choice. It would be to do them in a staged fashion. Well, This has been Richard Santucci. I'm a reconstructive urologist that spent 18 years working in busy hospitals, taking care of every reconstructive urology problem you can face. I love that job. I didn't need to change that job. But you know, out of the corner of my eye, I caught some really amazing reconstructive urology happening, but I wasn't part of it. And that bothered me. So I worked together with Curtis Crane, and we developed a system where I would come over to his practice. It's interesting to me because this is not commonly done, to have a mid-career surgeon switch his or her field completely. And we didn't know how that was going to work, him or me. So what we did was we set up a 5-month-long training program. We didn't know, would this take 1 month? Would it take 3 months? So we said we'll be safe, 5 months. But because Crane Center for Transgender Surgery is the busiest transgender center in the world, not sure everybody knows that, there's so many cases that I could just drink from the fire hose of learning how to do these procedures. And we weren't sure, gosh, will this take forever? Will it take, and the answer, I've got the answer for you, it's 4 surgeries. So by the 5th surgery, an experienced reconstructive urologist needs no assistance to do a perfect job. But of course we did many more than 5 surgeries. We did this for 5 months. So it's really turned out well. I love to be part of this community, and I want to thank you for signing on to my AMA.